Okay, so let's move on to our discussion of toxicology and how we'll handle these things in the emergency room. Let's move on to our next case, which happens to do with carbon monoxide. You are the chief resident of a great metropolitan training program at the time of the bombing of the World Trade Center. A total of 2,500 people come to your emergency department at the same time to be treated for smoke inhalation. Among them is a 68-year-old man with a history of aortic stenosis who had to walk down 90 flights of stairs. What's the most important initial test for this man? Now, this question really needs to give you a little bit more information, because here you're also asked to think about aortic stenosis in someone who just had an enormous amount of exertion. And as you know, in aortic stenosis, forward flow through the stenotic aortic valve might be limited, and especially during a time of great peak exertion, when myocardial oxygen demand is demanded in great supplies for all the exercising tissue, that demand might not be met. So you might be led to think here about problems with forward failure, maybe lactic acidosis, backwards failure and congestive heart failure and pulmonary edema. But try and focus here now on the mechanism of injury during this terrible explosion. And that was in a building, a huge building with tremendous fires. There is now an enclosed space. You're told he has to walk down 90 flights of stairs in this enclosed space. And we're assuming he's not burned. He comes to the hospital. And our concern has to be in an enclosed environment where there is a great fire blazing, we need to be concerned about inhalation of carbon monoxide. Now, who gets inhalation of carbon monoxide? Anybody who is exposed, particularly in an entrapped environment, in an enclosed environment, who has the poor luck to be near a fire where there's a lot of inhalation. Many, many things can burn and produce carbon monoxide. Gas, being located near a gas-induced fire. Wood, natural heating gas. All of these things are potential producers of carbon monoxide that can then be inhaled. Why is carbon monoxide such a problem? In fact, if you look at these patients, they might not look hypoxic. Their blood doesn't appear to be very dusky. The pathophysiology, and remember for step 2, about 10% is pathophysiology. The pathophysiology of carbon monoxide inhalation is it gets into your bloodstream and it very avidly, with great enthusiasm, will bind to the hemoglobin. The problem then is that oxygen doesn't have its usual binding sites to the hemoglobin, and although the hemoglobin levels will be normal, a hematocrit might be normal, the hemoglobin that's traveling around, all that usual amount of hemoglobin, is not carrying oxygen with it. So you're getting hemoglobin in adequate supply to the peripheral tissues, but it's not able to deliver sufficient oxygen. So what results here? Well, this results in a situation where there diffusely throughout the body is going to be tissue hypoxia. And when there's tissue hypoxia, as you remember or maybe don't remember from step 1, you go into an anaerobic metabolism mode. And when you go into anaerobic metabolism, unfortunately, one of the byproducts of that anaerobic metabolism is lactic acid. So these patients can develop a very severe lactic acidosis. And in terms of their blood count being normal, remember, even though they have a normal hemoglobin and a normal hematocrit, the right number of red blood cells, the hemoglobin in those red blood cells can't do what it's supposed to do, which is carry oxygen. And it's like you don't have enough hemoglobin containing oxygen in the cells traveling to your tissues. And this will therefore present like someone with a severe anemia, in the sense that there's not enough oxygen delivery to all of your peripheral tissues. These patients will therefore get a severe, often severe, lactic acidosis. What kind of symptoms will they get? Well, from a pulmonary point of view, they're going to appear short of breath. They're going to appear dyspneic and tachypneic. From a poor tissue perfusion of the brain, what are the other vital organs? The brain isn't going to get adequate perfusion. Patients will appear obtunded, confused, lethargic, somewhat encephalopathic. And again, that is not a very specific presentation of anything, that level of encephalopathy. But again, in the proper setting of entrapment in an enclosed environment, you must think about poor perfusion from carbon monoxide poisoning. And from a cardiac standpoint, another obvious vital organ that won't get enough delivery of oxygen, tissue hypoxia develops. What are the cardinal manifestations of poor blood supply of adequate oxygen to the heart? Well, you're not going to get enough supply to the coronary arteries, so you'll have anginal type pain. Again, the patient will look like they're severely anemic, even though there's enough hemoglobin. And again, that hemoglobin is there, but it's there without oxygen. It's there with the carbon monoxide bound instead. Patients will get chest pain. They may get arrhythmias, again, because the heart will not be adequately perfused. Inadequately perfused heart is an ischemic heart. Those ischemic segments can now become arrhythmogenic. And lastly, because of poor cardiac output, because of the poor pump function of the ventricular myocardium, because of, again, poor perfusion from the hemoglobin carrying the carbon monoxide, you're going to get a hypotensive patient. Who is at particular risk for this? Well, we said you need to be in the right environment to have been exposed to the carbon monoxide. A gas leak in an enclosed environment, even without a fire, you're going to have carbon monoxide exposure. A suicide attempt, which is a method, which is basically painless, is an attempt at committing suicide by carbon monoxide ingestion. That doesn't mean that you set a fire in the house and go and run into a closed space with a fire. How is the patient's going to try and commit suicide with carbon monoxide? Simple. You drive your car into your garage, you close the garage door, you close all the windows, you turn on the engine, you don't have to go anywhere, you just sit in the car, put on the radio. The carbon monoxide has nowhere to escape outside of the exhaust other than into your car and the enclosed garage. And basically you pass into a carbon monoxide poisoning, increased confusion, lethargy, obtundation to the point of coma, and then death when there's diffusely inadequate supply of oxygen. Unfortunately, tragically, some people try this method of suicide and they forget that their garage is connected to the rest of their home. And unfortunately, there have been situations where they are successful at killing themselves, but at the same time are killing family members who are asleep in the attached home up above. So this is a very scary way for the uneducated to commit suicide. The carbon monoxide in these patients can reach very high levels, and by the time they're found with the engine running, it's too late. On the other hand, if they're found before they have had toxic carbon monoxide intoxication, they're brought to the emergency room, and we will then manage them appropriately. How do we manage these patients? Well, we're going to, first of all, and again, they don't look cyanotic at the outset. They look like they're perfused. There's enough hemoglobin traveling around. You measure a carbon monoxide level. Now, you need to know the range of carbon monoxide levels. People who live in urban environments who are exposed to the ambient pollution of a busy city from cars and buildings and factories and incinerators, we're all exposed to carbon monoxide in these environments, particularly if you're a chronic smoker. The chronic smoking of tobacco cigarettes will increase your carbon monoxide levels. To what range? Well, they're elevated, but they're not greatly elevated, and they're typically elevated to up to 10%, in which case we're not worried about clinically important carbon monoxide intoxication. So smokers are walking around with CO, carbon monoxide. Smokers are walking around with less than 10%. When we're talking about 10 to 20%, we're talking about mild carbon monoxide poisoning. As we move up in terms of toxicity, 10 to even, let's say, 20 to 30. We're talking about mild carbon monoxide poisoning. When we talk about the treatment in a second, these are the patients who clear up very quickly. 30 to 50, we're talking about more severe, more complete saturation of the hemoglobin with carbon monoxide, and we're talking about a potentially very sick patient. And many patients who come in with over 50% carbon monoxide saturation of the hemoglobin are going to have potentially fatal carbon monoxide poisoning. And one of the great contributing causes to early death after a fire in the unfortunate burn victims is that initially you're going to have to worry about carbon monoxide poisoning. Now, what's our treatment of carbon monoxide poisoning? Again, we're going to do our initial blood gas. And remember, the oxygen in the blood can be normal. The oxygen in the blood, the PO2 in arterial blood gas, may be entirely normal. The pressure in the blood is normal, but the bound oxygen to the hemoglobin is where the problem is. There's PO2 flowing in your bloodstream, but it's not flowing bound to your hemoglobin, and that's the problem, because obviously the hemoglobin is the delivery vehicle, the delivery system to bring your oxygen to the tissues. Obviously, our first step in the treatment is to remove the patient from the source. Obviously, you're going to get the patient out of the garage. You're going to get the patient out of that room that's filled with smoke. You're going to bring them to the hospital, and now what you want to try and do is compete with the carbon monoxide that's already bound. You want to compete for those hemoglobin binding sites, and what you do is treat the patient with 100% oxygen. And hopefully, these very high levels of oxygen flowing into the respiratory system and then across your alveolar capillary membranes and getting into the bloodstream will competitively win over the carbon monoxide, and the carbon monoxide will be replaced with oxygen binding. In the most severe cases, merely giving 100% oxygen by face mask is not enough. Then we give the 100% by intubation, so we know we're getting 100% delivery right into the respiratory system. And in the most severe cases, hyperbaric oxygen is sometimes used to deliver the most concentrated form of oxygen, where the patient is placed in a hyperbaric chamber where there's a high concentration of oxygen, and oxygen then will even more rapidly replace the carbon monoxide from the hemoglobin. For instance, the normal, to give you an idea of the binding capacities of carbon monoxide to hemoglobin, a carbon monoxide intoxicated patient, the T-half, the half time of the carboxyhemoglobin until 50% is dissociated, is approximately 4 to 6 hours. Whereas if you're giving the patient 100% oxygen, you've reduced that binding time, that T-half, to about 1 hour, roughly 40 to 80 minutes. And if you're placing the patient in a hyperbaric chamber, because they have these very high levels of carbon monoxide poisoning, then you've lowered the T-half of the carbon monoxide poisoning to about 15 to 30 minutes. So you're going from about 4 to 6 hours when the patient comes in with carbon monoxide, and you're reducing it greatly to about an hour with 100%, 15 to 30 minutes with the hyperbaric oxygen treatment. Okay, and again, we're going to talk about carbon monoxide again. We'll refresh your memory when we talk about patients who are burn victims. And we'll talk about all the many complications that the burn victim is exposed to, chiefly in the first opportunity. You're going to assess their carboxyhemoglobin concentration and to determine exactly how at risk they are based upon the percentage saturated. Okay, let's move on to another situation. And that is the patient who you're told is brought to the emergency room, and it might be a pediatric question, where the ingestion is inadvertent, is accidental. The kid takes something out from underneath the sink and drinks it, doesn't know what he or she is drinking. Or, again, it can be part of a suicide attempt, a rather uneducated suicide attempt, because this is a hard way to kill yourself. You don't kill yourself immediately. You'll do it slowly and sometimes over years. And that is ingestion of some nasty stuff you find typically under your sink or in the bathroom. And I'm talking about ingestion of either, and it's typically oral ingestion, of either toilet cleaners, drain cleaners, dishwasher's fluid, liquid Drano is one of the most popular substances that people have found under their sink to try and kill themselves with. This stuff is either acidic, in the case of toilet cleaners, pool cleaners, drain. We often find that these are acidic. The alkali, which are in fact more harmful as an ingestant, a alkaline ingestion is typically more severe. There's more tissue damage with an alkaline ingestion than with an acidic ingestion. And that's because we have less acid floating around our bloodstream than we do bicarbonate to use as a buffer. So the acidic ingestion, again, can be very severe depending on the severity of the acid exposure. But in general, what you'll see on the boards is a patient who's drank liquid drain cleaner, which is an alkaline substance, and they've drank it. Now, they can be in kids, they can drink anything they find, and it will be often less in terms of the volume and perhaps less severe. Or if the child really is not paying very much attention to what they're drinking, they'll get down far more than they should in terms of the volume per body weight, and they can come in with quite severe an injury also. Okay? But generally, if the kid puts any of this stuff down, they're going to realize it is something nasty, and they're going to just vomit it back up. More commonly, you're going to see on the boards an adult who has a severe ingestion as a result of a suicide attempt. How do these patients look when they come in? They look acutely uncomfortable. They've now rinsed their mucosa of their mouth and their esophagus and their stomach typically with a potent alkali, like again, liquid drain cleaner. They have a great deal of oral pain. The esophagus is the organ that probably takes the single biggest hit. And so the esophagus can't do its job of swallowing. So these patients will often come in with severe oral pain and drooling, because when they're trying to swallow their saliva, has nowhere to go, it's coming up and they're drooling. And again, they appear acutely uncomfortable. They'll complain that anything that they try and sip down, because they've taken this nasty drink of liquid Drano, and now they're trying to rinse it away because they're in so much pain, they find that anything traveling down is causing pain, odynophagia. The problem in the esophageal exposure to these kind of substances, these caustic ingestions, is that the esophagus becomes extremely inflamed, and as it heals, it will cause stricture formation. So again, acutely, they're going to have severe pain, severe chest pain, odynophagia. As time goes by, over days or weeks, this will stricture down, cause dysphagia, an obstructive type. The most important assessment in the evaluation, the single most important test you will order, you'll be given a choice of CAT scans, chest x-rays, endoscopies, upper GI series, barium enemas. What you want to do is evaluate the patient immediately with endoscopy to assess esophageal competency in terms of the mucosa. If they have a great deal of inflammation, your big concern obviously will be about an acute esophageal perforation. And we're going to endoscope the patient early. Having said that, there's not that much we could do once we identify the severity of the ingestion. These patients have severe inflammation, and you don't want to give the patient an antiemetic to try and vomit up anything that's still in the stomach. Now, why is that? It hurts going down, and it's going to hurt come back up. All right? So remember, do not try and get the patient to clear out this alkaline substance, this corrosive substance, by vomiting intensely. Avoid at all costs antiemetics. We don't want to put a nasogastric tube down in these patients. The esophagus might be very friable, very vulnerable. Passing an NG tube greatly and significantly increases the risk of an esophageal perforation. Now, you might remember back some of your basic chemistry from inorganic chemistry in college and say, well, patient just had an alkali. Alkali is causing a lot of damage to the mucosa of the mouth, the hypopharynx, the esophagus, the gastric mucosa. But maybe it's not doing that much damage in the gastric mucosa, because I remember that alkali can be buffered by acid, and the stomach is making hydrochloric acid. So in fact, that does work, and that's why the esophagus is more likely to take a nasty hit from that ingested alkali. In the stomach, it's somewhat buffered, but that's natural buffering. What you do not want to do in a patient with a caustic ingestion, what you do not want to do is give the patient something to drink, ingest, that you will think will act as a buffering agent. In other words, if you have a patient with an alkali ingestion, do not give them dilute acid. Do not give them acidic citrus fruit drinks, because you think it'll buffer them. Any kind of buffering that you're going to introduce is just going to cause more thermal reaction. In plain English, it's going to burn things more. So you don't want to try and buffer these patients with acid if they took alkali, or with alkali like sodium bicarbonate if they drank something acidic. Here, the conservative management with very intensive support in terms of intravenous fluids is the most important approach. In general, we do not use prophylactic antibiotics. We do not use, in our ingestion patients, we do not use buffering agents. We do not use prophylactic steroids. It's a approach of watchful waiting and making sure that complications don't develop. What we do attempt in these patients is to basically dilute their ingestion, not buffer it, but dilute it. And for any exposure, whether it's to the eyes or the skin, most typically orally, we are going to wash it out intensely with plain old water. Okay? If the eyes have been exposed, we're going to rinse the eyes with water. Patient has swallowed the liquid Drano, we give them lots of water to drink down and try and dilute the concentration of the alkali. Now again, we said these patients have odynophagia, so it's very typical that they have trouble getting the oral fluids in. But again, it's important to, at that point, try to dilute the alkali as best as you can. Where else will caustic ingestions, particularly alkali caustic ingestions, show up on the boards? Well, it might show up on the boards, if you recall from the GI section, in a patient who presents perhaps years later with symptoms of dysphagia. Now, what kind of dysphagia do you assume this will be? Will it be a motility type dysphagia or a mechanical type dysphagia? And we spoke about, in the motility type dysphagia, we spoke about the motility disturbances in GI. Patients have what symptoms that tell you it's motility induced and not mechanically induced? What they have in motility type dysphagia is they have trouble with any ingestion, whether it's solids or liquids. And from the onset of the patient's symptoms, they'll tell you they're having trouble with liquids and soft food, as well as the harder, larger, chunkier foods. Whereas in a patient with a mechanical dysphagia, it is typically a progression of symptoms as the lumen becomes more and more and more mechanically blocked. And so at first, you could get down some pretty big foods, and it's really only the real big piece of steak that you didn't chew well enough or slice well enough that'll get stuck. With time, the patient tells you it's not just a big piece of steak or a big piece of dry toast or a big bite out of an apple, but it's softer foods that are getting stuck. A piece of chicken. Later, it might even be something like pasta. Something that is smaller as the lumen is getting small in the esophagus, a smaller food object can now get stuck as well. And ultimately, with the most severe mechanical type dysphagia, is going to progress from solids to softer solids to soft foods to liquids even. And by the time you have a patient with dysphagia to liquids that has had that progressive nature, you know you have a well-advanced dysphagia. And the lumen might be literally no more than a pinhole. Okay? So if they give you a clue that the patient is presenting with mechanical dysphagia over weeks to months, and they don't give you any history of smoking or drinking or risk factors for esophageal cancer, they make it clear that this is a progressive picture and not a single episode of what we call steakhouse syndrome, where out of the blue, the patient eats a real big piece of steak and it gets stuck. What entity is that? That's probably a Schottky ring. But let's go to the patient who has this progressive type of mechanical dysphagia, doesn't smoke, doesn't drink, does not have 30-year history of gastroesophageal reflux, so we don't think the patient has a Barrett's esophagus with an adenocarcinoma. But they do tell you that way back, the patient was severely depressed, or maybe schizophrenic and delusional, and they've had multiple suicide attempts. And maybe they'll even be kind enough to tell you that one of these suicide attempts was with an ingestion of something in the house. That should suggest to you that they're telling you the patient had an ingestion of some alkaline substance that didn't cause a perforation of the esophagus early, didn't cause a stricture of the esophagus early, but with time, there's been increasing scarring and fibrosis, and now the patient is presenting late with symptoms of a alkali ingestion with dysphagia and a mechanical stricture. And these strictures happen to be pre-malignant as well and are at risk for, because of the chronic inflammation and scarring, are at risk for the development of esophageal cancer, but of the squamous type. Okay, remember, most esophageal cancers are squamous. The ones that are increasing, though, in greatest frequency in the esophagus are the very bottom of the esophagus, where the esophagus meets the gastroesophageal junction, and that's after long-standing GERD, long-standing gastroesophageal reflux. The patient develops a Barrett's esophagus, predisposes to low-grade dysplasia, high-grade dysplasia, and finally cancer. Okay? That is the kind of esophageal cancer that is an adenocarcinoma. in the lye ingestion, in the liquid Drano ingestion. There's chronic scarring, as with the great majority of the esophagus, the mucosa is squamous, so the patient can have that degenerate into a squamous carcinoma. That's the long-term sequelae of a caustic ingestion. But to sum this up, remember, you're going to see the patient in this setting. We're talking about emergency room setting with a patient who just had a suicide attempt or a pediatric patient who inadvertently drank this stuff. There, what you're going to do is start giving the patient water. Don't give the patient buffering agents, and you want to perform as a diagnostic test an early upper GI endoscopy to assess the integrity of the esophageal mucosa. Okay? That's our approach to the caustic ingestion. The next topic we're going to discuss is the patient with digoxin toxicity. Now, this patient can present as a straightforward outpatient cardiology patient who's developing some new problems, which we'll talk about in a moment. Or, again, it might be part of an acute presentation. Again, maybe a suicide attempt, typically an older person. Those are the folks who have digoxin around the house. And they present with an acute problem from the digoxin toxicity in the emergency room setting. So in talking about digoxin toxicity, let's talk about it now in both the emergency room setting, how it presents at home perhaps, and how it might present in the cardiology office or the outpatient office. Now, before we talk about the toxicity presentation, you have to remember that the board is not always going to make it very simple by telling you the patient has just now ingested a huge amount of digoxin. They might just tell you the patient's on digoxin among 8 other medications, okay? Or they might just say the patient's on a number of medications which they do not remember but are treatment for, quote, heart disease. So let's talk about first which patient might be the clue that the patient's on digoxin. If they're not telling you specifically, the patient brings their digoxin bottle, or there's a medication list that says the patient's on digoxin, which patients, in terms of an overdose, whether it's deliberate for a suicide attempt or inadvertent, which patients will be on digoxin. So where's digoxin helpful? It's helpful in terms of patients with congestive heart failure. And if you think back to cardiology, is it the patient who has the big dilated left ventricular failure, volume overloaded patient with an S3? Or is it the patient with the hypertrophic, very strong-walled muscle of the ventricle, who has a hypertrophic cardiomyopathy with an S4? Obviously, it's the patient we want to use digoxin, the patient with the dilated, poor systolic function. So it's CHF, particularly CHF with his left ventricular dilation on S3 to indicate volume overload. What other patient will get CHF? Well, CHF is a particular rhythm that digoxin is used, not by itself, but often in conjunction with another medication, and that's atrial fibrillation. And again, in atrial fibrillation, is digoxin used to convert the rhythm to normal sinus or to slow the rhythm? This is the key question. And the answer is digoxin does not convert the patient to normal sinus. Digoxin will slow the rhythm, the ventricular rate. It will slow the ventricular rate by what mechanism? By blocking the AV node. All right? We talked about this when we talked about supraventricular tachycardias. Let's make this a little more accurate. If we're blocking the AV node, all these fibrillating foci from the atrium, more and more of them will be blocked. Fewer will get down to the ventricular conduction system, and you'll have a slower ventricular rate, which is particularly important in patients who have a poorly contracting ventricle, because if you make the rate too fast, there's not enough time for that ventricle to fill. Again, with a faster heart rate, diastolic filling time is shortened, less time for ventricular filling. So it can exacerbate a patient who has congestive heart failure, atrial fibrillation. And so digoxin is ideal for the patient with the left ventricular dilation, who has an S3, a volume overloaded ventricle, a ventricle that has systolic dysfunction, and who has developed atrial fibrillation. And those often coexist, because in a big dilated heart, the normal sinus to AV node conduction doesn't work, because think of it as the atrium stretching, and the normal conduction systems no longer function. So AFib in a patient with LV dilation and an S3, classic patient who you can anticipate should be on digoxin, particularly with the atrial fibrillation. One other situation where digoxin is used is not only in AFib, but other patients who have supraventricular tachycardias, whether it is an atrial flutter, whether it is an AV node re-entry tachycardia. In all these situations, digoxin works by the same mechanism it works in AFib, and that again is to cause increased slowdown at the AV node, blocking more of the conduction from higher up, so there are fewer transmissions down to the ventricular conduction system. Okay? So these are patients who might be on digoxin. And if you look at these patients, these will probably be your older patients and who are on digoxin. Now, who is more prone to digoxin toxicity? Well, in general, you need to remember that digoxin is metabolized and excreted through the kidney. So patients with CHF who have poor forward flow to the kidneys often have an elevated serum creatinine, telling you this patient has renal insufficiency, usually on the basis of poor forward flow. The BUN to creatinine ratio is elevated, and this patient has renal insufficiency of a mild or moderate degree. And you've given the patient too high a dose of digoxin. For instance, a patient they tell you has a creatinine of 2.0, and you start them on a dose of, say, 0.25 milligrams of digoxin a day. Now, you don't need to memorize doses for step 2, but the major drugs in each category, it's worthwhile knowing what the typical dose is. And for digoxin, in a healthy person, 0.25 is sort of a full dose to be given on a daily basis, PO, orally. If you have a patient with CHF and they tell you the serum creatinine is elevated, 1.5, 1.8, 2.0, you do not start the patient on a dose of 0.25 milligrams. You start at, say, 0.125 milligrams. Typical starting dose of DIG is about 0.25. However, if there is any reason to think that the patient is at risk for DIG toxicity, you start at, say, 0.125. Or in the patients with even more advanced renal disease, you might even start at 0.0625 milligrams a day. So one way the question might present, the case scenario might be presented to you, is you're starting a patient and their serum creatinine is elevated, and you started the patient on too high a dose. You can fairly anticipate that that patient is going to develop DIG toxicity in that question. Another scenario where you'll see DIG toxicity, similarly with renal insufficiency, is when the patient is started on a typical dose while their renal function is okay, and as their CHF gets worse, or as perhaps their diabetes gets worse and progresses, they develop progressive renal insufficiency. And the digoxin dose hasn't changed, but the digoxin excretion has changed. So the question may present to you a DIG toxic patient who is on their typical dose of digoxin that's been stable for a while. And since the patient saw you 6 months ago, things have gotten worse. They've developed signs of DIG toxicity, which we'll talk about in a moment. And they tell you the serum creatinine went from 1.2 to 1.9. So something has changed in the body's ability to get rid of the DIG, and you've done nothing to reduce the daily DIG level. So whereas you might have had a therapeutic digoxin level in the serum when you were 0.25 and the creatinine was 1.0, now that the creatinine is 1.8, 1.9, having left the patient on this dose is going to tell you that the patient has developed DIG toxicity. So the patient might not start out in the question with renal insufficiency, but over time they stayed on the same digoxin dose while their kidneys have gotten worse, anticipate that they will become DIG toxic. So changes in renal function are an important consideration to think about, that your patient's about to develop DIG toxicity in that question. The other very important mechanism whereby a patient can suddenly become digitoxic, dig meaning digoxin toxic, is the patient in whom a new medication is introduced. And there's one classic drug-drug interaction that you must know for digoxin. And that is a patient with digoxin who now has a certain other drug added. What drug is that? I'll give you a clue. It's also used in patients with atrial fibrillation. That drug is quinidine. Remember, digoxin is used to slow atrial fibrillation. Digoxin does nothing to convert the patient back to sinus. So if you have a patient with AFib, they're often on digoxin to slow the ventricular rate, and then quinidine is added. And with the addition of quinidine, the dig level will rise. You can assume that if a patient is started on quinidine on the boards, and the patient is already on dig, I can virtually assure you that that question is about dig toxicity. And they want you to recognize that whenever you start somebody who's on digoxin, you start them now on quinidine, you must automatically lower the dig dose. If not, that patient, I could almost guarantee you, about to develop dig toxicity. Okay? So remember, developing renal insufficiency, you have to reduce the digoxin dose. Patient has quinidine added to convert their AFib, reduce the digoxin dose. If not, I can bet you that patient's about to develop a dig toxic symptom. Now, what are the digoxin toxic symptoms? And let me mention one more factor that predisposes the patient to digoxin toxicity, and that you need to know also. We talked about so far renal, increased risk of dig toxicity. Renal function declines. 1. 2, another major factor. Quinidine is introduced. Number 3, an electrolyte disorder, hypokalemia. Hypokalemia. Hypokalemia for a given dig dose puts the patient at greater risk for digoxin toxicity. Now, what are the dig toxic symptoms? Let's talk about the more general, non-specific ones, and then about the more specific ones that the patient will have. In terms of the organs involved, in terms of dig toxicity, in terms of the clinical presentation, you want to think about the non-specific GI symptoms, nausea, vomiting, a little queasy, diarrhea. The CNS, which can be of the generally non-specific type, a little confusion, a little forgetfulness, more confusion, a little lethargic. Those can be symptomatic of anything. But the CNS symptom that is very suggestive is that the patient develops new changes in blue-green color, visual changes. In other words, they become colorblind, okay? They become colorblind on any drug. I bet you they're on digoxin, okay? So that's actually very suggestive, very specific. Those are the non-cardiac digoxin side effects. And the one, again, the specific one that should clue you in that you're talking about a dig toxic patient is the onset of visual color deficit. Now let's talk about, and in fact, the most important manifestation of dig toxicity, and that is the cardiac arrhythmia, as you can see. Okay. Some of these are, again, cardiac arrhythmias that are not specific for dig toxicity. Some of them are very suggestive. The one that is most common is actually just plain old PVCs, additional premature ventricular contractions. That doesn't clue you into digoxin per se. They'll probably have to give you something with a little more specificity for dig toxicity. That is paroxysmal sudden atrial tachycardia. New onset, it's atrial narrow complex tachycardia with varying amount of AV node block. So would you expect this kind of rhythm to be regularly irregular, such as beat, 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 beat? Obviously that's irregular, but it's irregular in a regular pattern. I wouldn't expect that because I've just said it's varying amounts of AV block. And why is that? The digoxin, besides predisposing to paroxysmal atrial tachycardia, and the reason it does that is because you've introduced AV node block. So the atrium, think of it as the atrium trying to overcompensate. And variable amounts of atrial beats will get through to the ventricular conduction system. So you might have something like beat, 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 beat. You see different amounts of block between the tachycardia. That's very characteristic of digoxin toxicity. Another kind of, and extend that, the knowledge of that pathophysiology, that pharmacology, to the next level, and that is greatly increasing AV node block with the greater dig toxic patients, and then you'll get high-grade bradycardias, where you'll have escape rhythms from the bundles that are lower down, and you get a non-P wave bradycardia. No, an escape rhythm below the AV node that gives you a much slower rate. The lower down in the conduction system you go, the slower the escape rhythm. So you might have a regular bradycardia, regular in terms of it is a consistent interval between each slow beat. So the new onset of a nodal bradycardia, you have to think about dig toxicity. Okay? And that will look like bradycardia, like a sinus bradycardia, but no P wave. So it might look okay? Regularly spaced intervals, no P waves preceding the QRS. Okay? That's a nodal bradycardia. That's dig toxicity. Now, how do we treat a patient with digoxin toxicity? Well, there are several things. Number one, you have to think about what's correctable. If the patient was hypokalemic, the easiest thing to do is to correct the potassium. And if you're correcting potassium and you want to do it rapidly, you can't give potassium intravenously very rapidly because you'll stop the dig toxic rhythm, but you'll stop the heart at the same time. Remember, potassium infusion is a very effective mode of suicide. So you have to be very careful about trying to replete a hypokalemic patient intravenously. And in fact, you get much quicker, much larger doses by giving the patient big doses of oral potassium. So number one, you correct what's correctable. You correct the hypokalemia. Number two is you think about which specific one of those ventricular or atrial arrhythmias we're dealing with. If the patient has a nodal bradycardia, then we'll treat the patient like any other bradycardia that the patient might have that's symptomatic. And we'll give the patient atropine. If necessary, we'll even give the patient a pacemaker if the bradycardia is prolonged. If the patient has a life-threatening dig toxicity, and sometimes this takes the form of not just a few PVCs, but many, many PVCs resulting in perhaps severe ventricular arrhythmias, ventricular tachycardias, we could treat the patient with, again, it's used in a dig toxicity, life-threatening situation. We could use the Digibind antibodies. These are antibodies that have been created, directed specifically against the digoxin in the bloodstream. And that is reserved, the Digibind is reserved for patients with life-threatening arrhythmias from digoxin toxicity. Other drugs that you might see in the choices, if they don't give you a Digibind, digoxin antibody as a choice, for a patient with digoxin-induced ventricular arrhythmias, the drugs that work are drugs like Dilantin, phenytoin, an anti-seizure medication, and lidocaine. Those are the antiarrhythmics I would use if the choices don't include digoxin antibody in a patient with severe ventricular arrhythmias from digoxin toxicity. And again, the most important factors are inappropriate dosing because you haven't considered the patient's renal function, or someone has just introduced quinidine to the mix, or the patient is hypokalemic. Let's move on to talking about some other intoxications which can be deliberately done, maybe as a suicide attempt again, or can be inadvertent because these drugs are used for recreational use. And we could start in the order of our syllabus. We're talking about opiates, narcotics. In terms of the street drugs that are used, most commonly heroin is the drug that's being used. If you're reading the newspapers recently, you know that there's a prescribed long-acting narcotic that's a once or twice a day drug with a slow release, OxyContin. OxyContin is basically a form of morphine contin that is in a long-acting formulation. And what's done is sometimes these pills or these capsules are ground up and they're taken all at once. When they're ground up, they lose their time release capability, and now you have this huge surge in narcotics in the bloodstream. Heroin, OxyContin, prescription analgesics, and you have to worry about this in a patient who is given chronic narcotic analgesics, either for a legitimate amount of pain or they've obtained prescription narcotics for abuse. You have to worry about opiate addiction and opiate overdose. Now, opiates is an easy question on the board because there's one particular finding in terms of overdose that is very, very suggestive of a narcotic overdose, and that is on the exam, before having to do a very sophisticated exam, you'll take this patient who's either obtunded, lethargic, stuporous, comatose, and you'll pick up their eyelids and you'll see they have pupillary constriction. That, or the so-called pinpoint pupils. If they're symmetric, they're pinpoint in an obtunded patient, you know, virtually know for sure that patient has a narcotic overdose. Without any other clues about the patient's occupational, environmental history, their past medical history, their drug history, pinpoint pupils in an unconscious patient, always think narcotics first. And then again, part of that cocktail that you're going to give your unconscious patient with an unknown etiology of that loss of mental status is naloxone, Narcan. Naloxone, again, the rest are glucose and thiamine. Okay? What do opiates do? How will they affect the patient who's presenting with an opiate overdose? Pupillary constriction. It is in general a depressant. People who shoot heroin are not high and jumpy and agitated. They're very mellow, they're very slow, they're very calm. Their heart rate is calm and slow. They're bradycardic, they're hypotensive, they're hypothermic. They're not all heated up, they're hypothermic, and their mental status is poor. They're slurring their speech. They might give you clues in the question of past drug abuse, hints of old cellulitis on the exam, hints of old endocarditis on exam. The valve that's most commonly involved in heroin-induced or drug-induced endocarditis is which valve? Which is very uncommon in the absence of illicit drug use. It's the tricuspid valve, tricuspid regurgitation, with the infection being Staph aureus from injected narcotics. And what's being injected along with the heroin and the talc and the baby powder and the bicarb that the street dealers mixing in to dilute your heroin is Staph aureus. That's not being mixed in with the talc, but it's being mixed in with your skin flora. And as you're injecting an unsterile area, you're introducing Staph aureus. Staph aureus likes to come to the tricuspid valve in drug abusers, in intravenous drug abusers, and cause tricuspid regurg. All right? So if they tell you the patient has a questionable history of drug use, but they tell you on the question the patient has tricuspid regurgitation, and they're not going to say the word patient has tricuspid regurgitation. They'll tell you the patient has a systolic murmur at the tricuspid area that increases with inspiration. A murmur that increases with inspiration is a right-sided murmur. okay, as opposed to mitral valve regurgitation, which is also systolic, heard best at the apex going out to the axilla. Mitral regurgitation murmur does not increase in loudness with inspiration. A right-sided equivalent of mitral regurg, which is tricuspid regurg, and holosystolic will increase in amplitude, be louder when the patient takes a deep breath. Okay? So that might be a history that the patient is using narcotics in the past, and now they're not necessarily coming in with a febrile illness and a new murmur, but they're coming in obtunded and hypothermic and hypotensive and bradycardic. Think narcotic overdose. The big key is open the eyes, look at the pupils. If they're pinpoint, shoot the patient with some Narcan, naloxone, which frankly should have been done even before the patient got to hypotensive and hypothermic and bradycardic. Again, fortunately with narcotics, we do have a specific antidote, and that's naloxone. There is the theoretical concern, and in fact it's a real concern, that patients who are chronically on pain medications or frankly chronically abusing heroin and will come in with a severe narcotic overdose, that when you give them naloxone, they're going to have an acute withdrawal syndrome, which the patients will basically develop the exact opposite of a narcotic overdose. They'll become very agitated, very shivery, very jittery, very cold, with chills, not because they're hypothermic, but because they're having shaking chills. They wake up and they become very agitated to the point of seizures. So again, if you have to give the chronic drug abuser or the chronic analgesic user naloxone, because at the moment you're seeing them in the question, they're barely breathing, because the chief mode of death in narcotic overdose is depression of the CNS respiratory drive. If you must give them naloxone to save their life, be prepared then to watch the patient wake up and then go on to seize and be hyper agitated. Okay? So it's a tricky balance. But again, if you're confronted with a question where the patient is not breathing or barely breathing, has pupillary constriction, and you have good evidence that the patient has a narcotic overdose, you can't worry about what's going to happen if you reverse the narcotic. First, you have to get them breathing again. You reverse the narcotic. Okay. Let's move on to another drug of abuse. There's no there's a rare medicinal use for this drug, and that's, well, I won't tell you what the drug is. I'll describe the patient. You tell me what drug it is. It's a patient who doesn't look like your typical homeless person who might be in and out of homeless shelters, in and out of mental homes, in and out of prisons, and using intravenous drugs. Now, that's not to imply that all homeless people, all schizophrenics, or all prisoners have used intravenous drugs. But those populations have greater incidence of drug abuse, so that might be a social clue in the question that they're telling a patient has IV drug use. On the other hand, let's say they tell you a very distinguished-looking banker or doctor is brought into the emergency room, nicely dressed. They're brought in by a neighbor or a spouse or a friend because they've been very agitated, very irritable, very hyperdynamic. Their heart rate is 150. Their blood pressure looks like it's going off the charts. They're red, they're flushed, they're fidgety, they can't sit still. The opposite of a narcotic overdose, this is an agitated patient. Not bradycardic, but tachycardic. Not hypotensive, but hypertensive. Okay? No pupillary constriction. And sometimes step 2 questions that have literally told you this kind of patient, and then on your exam, you've looked in the nose, and there is a perforation of the nasal septum. Now, other than telling you the patient is found with a bag of cocaine sticking out of their nose and blood dripping from the other nostril, this is obviously a cocaine intoxication. They can't make it easier than that. And they have said there have been patients who they present with this agitated phase who you might even find white powder in their nose, or you might find evidence of nasal septal injury from chronic snorting of cocaine. And snorting cocaine is not the only way to get into your blood system. The most likely way that you'll get cocaine overdose is by smoking it. And it can be baked down into a small rock and smoked in a pipe. That's called crack. And that is inhaled, and you deliver very high doses of cocaine directly into the bronchi that way, and you get much higher blood levels, much higher risk of cocaine overdose. It can also be injected, and as an injection, also greater risk of high serum cocaine levels and a very toxic, agitated-looking patient. And remember, when you're injecting cocaine, there's nothing that protects the patient from a cocaine injection from developing endocarditis, just like the heroin injector. It's not the drug you're injecting that puts you at risk for endocarditis. It is the fact that you're using unclean needles and you're not prepping the skin in a sterile way usually when you're shooting drugs. So again, cocaine injectors are at the same risk of endocarditis as the heroin injectors. The systemic signs of a cocaine overdose, however, are almost exactly the opposite of the heroin overdose. And think about the pharmacology of cocaine. And that'll help you remember the clinical presentation and the differential diagnosis. Cocaine works by inhibiting norepinephrine reuptake at the synapses. So you have this constant supply of norepinephrine to cause stimulation. So everything is getting norepinephrine stimulation. It's like a norepinephrine tumor. In other words, a pheochromocytoma has a very similar presentation. Okay? Very tachycardic, agitated, hypertensive patients. And these patients get very tachycardic and very hypertensive. And because norepinephrine can stimulate alpha receptors, they can get coronary vasospasm. So these 30-year-old healthy bankers and doctors who are spending their riches on cocaine will come in with severe chest pain. These are 30-year-old, no history of coronary disease. They just ran a marathon yesterday. They can't have any serious atherosclerotic disease, and they don't. But what they've done is dramatically increase their double product with their cocaine, increasing heart rate, increasing blood pressure, and then they've caused intense coronary vasospasm by alpha adrenergic stimulation from the norepinephrine, and now they're having MI. Increased demand from their hypertension and tachycardia, decreased flow because of coronary vasospasm. So these patients can present with anginal-type symptoms that are very real. They can present with EKGs that are consistent with an acute myocardial infarction, and in that setting they can also present, besides tachycardias, tachyarrhythmias, particularly ventricular arrhythmias. Right, so these patients can come in and require the entire gamut of treatment for ventricular tachycardia that we spoke about earlier. Okay? Does cocaine have an antidote? No. We're going to treat the specific symptoms. If the patient is very hypertensive, we'll think about what antihypertensive we should give them. What antihypertensive makes pharmacologic sense knowing how cocaine works. It stimulates alpha receptors, and it also norepinephrine binds to beta receptors. So the ideal drug would be a beta blocker as well as a drug that has alpha blocking properties. And a drug such as labetalol, which is both an alpha and beta blocker, can be the drug of choice for a patient with cocaine overdose. Why would I prefer an alpha-beta blocker to a pure beta blocker, like, say, atenolol or propranolol? Because, again, norepinephrine binds not only to beta receptors, and by blocking the beta receptors, I will reduce the heart rate, I will reduce the blood pressure, but at the same time, I'm now leaving the alpha receptors unopposed. And the norepinephrine that's hanging around from that cocaine overdose is going to bind to my alpha receptors, and that will cause more vasospasm, coronary vasospasm, and more diffuse peripheral vasospasm, and that will tend to keep the blood pressure up. So the ideal drug, as with the patient with pheochromocytoma, to block the tachycardia and the hypertension is a combined alpha-beta blocker like labetalol. That would be the drug of choice that I would pick if I was given a selection of drugs to slow down the tachycardia, a supraventricular tachycardia, and to slow down or lower the blood pressure. Labetalol would be the ideal drug. What else can we see besides the cardiac manifestations? Let's extend the concept of hypertension. Where can hypertension cause a very severe acute complication? It can cause very high blood pressures, leading to very high perfusion pressure in the brain, so high that can blow out a blood vessel, and it can induce a subarachnoid or even intraparenchymal hemorrhage. And so the patient may present with an altered mental status. Again, we said they're generally agitated, but an altered mental status and focality on neurological exam. I'm going to worry that they had a hemorrhagic stroke. All right? Or if they present with symptoms of severe neck stiffness, the worst headache of their life, very hypertensive, I'm going to worry about maybe they blew out a vessel that led to a subarachnoid hemorrhage. These are all possibilities in the patient who is very hypertensive with a cocaine overdose. Along the lines of, again, CNS hyperactivity, besides the findings of changes as a result of the hypertension in the brain, the hyperexcitability of all this norepinephrine in the brain can lead the patient to have not only the tremors, but the tremors get more severe, and they get a progression to the point of a seizure, a grand mal seizure. Again, all consistent with excitability, norepinephrine excess. The excitability extends from the heart to the brain to the peripheral tissues, and the muscles might get so overworked, typically with a seizure, that the patient might develop rhabdomyolysis. Okay? So if they tell you a patient was found unconscious and you have reason to suspect it's a cocaine overdose, and they come in and they tell you the creatinine is 30,000, yes, creatinine can come from a heart attack, but you'll never get a creatinine of 30,000, not creatinine, a CPK. A CPK is 30,000. If the CPK is 30,000, that's only one thing. 10,000, 20,000, it's rhabdomyolysis. They ask you, what is the cause of this patient's elevated CPK? It's not a myocardial infarction. There's CPK in the heart. It's not a big stroke, even though they may have a stroke, the CPK in the brain. Nothing gives CPK in the 5, 10, 15,000 range except intense muscle activity from the cocaine and rhabdomyolysis. I said that they have elevated creatinines. That, in fact, is true. When any patient has rhabdomyolysis, they can start plugging up their renal tubules, and these patients with cocaine overdose, seizures, rhabdomyolysis can also develop renal insufficiency. We talked about the treatment for the tachycardia and the blood pressure. The treatment for the CNS excitability, namely the seizures, is something to calm down that hyperexcitability in the CNS, and for that situation we'll use benzodiazepines. Right? Does not mean every patient who comes in with a cocaine overdose gets a benzodiazepine, but the patient who is hyper-agitated, who has had seizures, a drug of choice would be a benzodiazepine in the patient with cocaine and the hyperexcitability. And we'll take a break here. Okay, let's move on to our next potential overdose. And they might not tell you the name of the drug. They might tell you what the patient's taking the drug for. Patient has, let's say, a panic disorder, an anxiety disorder, severe insomnia. And sometimes these are in association with patients who are depressed. So besides the antidepressants, which we talked about, particularly tricyclics, for panic disorder, anxiety disorder, insomnia, we're obviously talking about benzodiazepines. So patients who are taking benzodiazepines in association with a depressed state are obviously prone to overdoses, and it's usually a polypharmaceutical overdose. People are rarely successful in killing themselves with pure benzodiazepines. Diazepam, and the whole family of benzos that are often around the house, often prescribed to patients with other psychiatric issues, rarely are enough to kill themselves. However, having said that, a big tricyclic overdose with a big superimposed benzodiazepine overdose, with a superimposed perhaps barbiturate overdose, there you have a potential lethal combination. What are the signs and symptoms of a benzodiazepine overdose? Well, basically, benzodiazepines are, again, not an excitable drug, but a suppressing drug. And in case you're asked from step 1, or somehow they make reference to it, they bind to specific benzodiazepine receptors in the brain, which stimulate transport of chloride, and it causes, again, neurodepression. Not neuroexcitation, neurodepression. So patients look somnolent, they look tired, they look lethargic, they might be somewhat dysarthric, their speech may be slurred as they're walking, they're stumbling, they may be ataxic. Again, not going to usually be successful as a only drug in committing a suicide, but it does cause some respiratory depression. Let's think back to our basic management of an overdose. If a patient comes in and we have evidence to think that they took it within the recent hour or so, we're going to try gastric emptying, particularly an antiemetic like Ipecac. If it's later on, more than an hour or so, we're going to think about how to bind the drug. We're going to use charcoal as an effective agent. Benzodiazepine does have a specific antidote. Right? We've talked about only a few drugs that have specific antidotes for a given overdose. Benzodiazepines is one of them. And the specific antidote there is flumazenil. Flumazenil is a specific benzodiazepine antagonist and can sometimes be used therapeutically and can sometimes even be used diagnostically. What do we mean by this? Let's say a patient comes in lethargic. They've gotten in the field by the paramedics, they've gotten the, quote, cocktail. They've gotten the naloxone, they've gotten the glucose, and they've gotten the thiamine. Patient doesn't wake up at all. They come to the hospital, the emergency room, they're assessed. Hemodynamically, they may be stable, but they're obtunded. They're not really arousable. But again, they don't look like they're in a life-threatening situation. They're not hypotensive. They might be a little bit less than a normal respiratory rate, let's say 6, 8, 10 times a minute. Maybe they're a little hypoxic. Maybe they're a little hypercapnic, meaning a mild respiratory acidosis. But these are not patients who look like they're about to die. So we want to know, is it possible that all of these symptoms are being contributed to by a benzo overdose? And in this regard, flumazenil is very effective as a diagnostic test. You give the patient an injection of flumazenil, and the patient starts to perk up and wake up. Nothing else will be reversed with flumazenil. That tells you part of the, at least part of the cause for the patient's CNS depression and perhaps respiratory depression is from the benzodiazepine. So flumazenil can be used to help you determine what the patient has on board as you're trying to figure out what else the patient may have taken. Secondly, it can be given as repeated injections if you find that the patient's a lot deeper in terms of their mental status. They're a lot more deeply obtunded than you'd like. Then you can give repeated infusions of flumazenil. The qualifying statement to that is that patients who have lots of benzodiazepines at home have often been on them for a long time because of their anxiety disorder, their panic disorder. And now you're taking a patient who might not be or is probably not in a life-threatening situation from their benzo overdose, and now you're giving them flumazenil, and you're going to awake them, which is nice, but you're going to again reverse their chronic benzodiazepine dependence and get an acute withdrawal syndrome, where the patient becomes very agitated, even to the point of seizures, maybe as they start vomiting and they're obtunded, they're going to aspirate. So be very cautious about reversing a benzo overdose in someone who's a chronic benzodiazepine user. This comes up in a different situation. Let's say you're called to the recovery room from a procedure, from let's say an endoscopy, and the patient is more hypercapnic than you would like. A measurement of the PaCO2 is too high and they're a little too hypoxic, and you know the patient was just given nothing but a benzodiazepine. Before you go straight forward and give the patient their flumazenil, you need to go to the medication list in that question and see if the patient has been on chronic benzos. Again, if the patient is quite deeply lethargic, they might be a little hypercapnic, a little hypoxic, but hemodynamically stable, it might be a better idea to give them some O2 supplementation, again, as long as they're hemodynamically stable, rather than try to acutely reverse them with flumazenil and potentially induce a seizure. Okay, so flumazenil, again, in a chronic benzodiazepine user, be cautious. Similarly, in the chronic narcotic user, be cautious about using naloxone. Naloxone, you have a little bit more justification to use because the narcotic overdose is far more likely to be in a life-threatening situation than your benzo patient, in whom you'll be tempted to reverse with flumazenil. Okay. Now let's move on to another potential overdose, and I'll tell you that this is a patient who, say, has a history of seizure disorders and comes in obtunded or lethargic. So I'm going to think back to my neurology and think about what drugs are used for seizures, and there are many, but one of the ones that are used that can cause severe respiratory depression, and again, patient will come in hypotensive perhaps, bradycardic, and most importantly, they will have reduced mentation and respiratory depression. I want to worry about a phenobarb overdose. Now, all of these drugs that we've talked about the acute management while the patient is right in front of us in their acute overdose state. In all of these drug overdoses, as part of the diagnostic evaluation, besides looking carefully at the history, besides looking on the physical for signs per se, for instance, of old drug abuse, we're going to send urine and blood toxicology screen. And that might come back and give us a very specific answer. But again, the boards is not going to tell you send the toxicology screen, it comes back with a benzo overdose. What do? They want you to make the diagnosis based upon that initial presentation, as if you're seeing the patient, the first responder in the emergency room or in the field. Okay, and in that case, you're not going to have the results of a toxicology screen. If you're given the option to, as part of the diagnostic evaluation, to order a toxicology screen, that's a fine choice. But it's not going to be the first thing you're asked to do when you're approached by an overdose patient. They want you to know how to identify the specific overdose by the history or the physical, and how to make that diagnosis quickly and how to start trying to treat that overdose. Okay? So yes, all of these things we can determine with a measurement of a toxicology screen, whether it's blood or urine, but again, that's not going to be how the board presents the question. Now, so let's talk about our patient who has this history of seizure disorder, and they have this respiratory depression and decreased mentation. I'm worried about a phenobarb overdose, phenobarbital. Not used very commonly as an anti-seizure medication, in large part because it is so commonly abused, either as a drug of recreational abuse or a drug for suicide attempt. Because phenobarb, unlike benzos, phenobarb is sometimes effective at inducing an effective suicide, because the respiratory depression you get with phenobarbital in an adequate dose is often sufficient to cause respiratory depression to the point of hypercapnia, respiratory acidosis, to the point of death. So the phenobarb patient you might need to approach much more aggressively than the benzo overdose. And the barbiturates, the phenobarbital patient, for instance, this patient can have such severe CNS depression that if you were to do an EEG in this patient who looks so unresponsive that they're dead, this patient might have an EEG that looks like they're dead. Namely, a flatline EEG in this patient who is barely or not breathing at all and is hypotensive, perhaps no palpable pulse. And if you have a very strong suspicion that the patient has a phenobarb overdose, you cannot call the patient brain dead even with an absent rhythm on the EEG. And that's because the phenobarb can greatly suppress the activity you would see in the EEG while there is still some background brain activity. And those patients, there is a specific approach to the patient with phenobarb overdose, and that is to try and increase its excretion by treating the patient with bicarbonate, alkalinizing the patient and inducing a diuresis, and you'll hopefully flush out phenobarbital that way. While you're doing that, you're obviously going to support the patient hemodynamically with fluids, pressors if necessary. If the patient is hypercapnic, you're going to support the patient with intubation as well. Don't call it quits in the patient with a phenobarb overdose until you've made sure you've done everything you can to reverse the overdose, because the patient might simulate death even while there is still hope for recovery. Okay. Let's move on to yet another class of drugs that can be used in recreational drug abuse, and that is the family of drugs perhaps the most abused recreational drug, marijuana. And that is among the, quote, hallucinogenic drugs, drugs that will give the patient perhaps visual, auditory hallucination, is the mildest, least dangerous of the drugs, and probably the most used. And this is marijuana and other drugs in the hallucinogenic class that have totally different pharmacology, but perhaps the same symptomatology it will produce in the patient who presents in the emergency room are things like LSD, are things like mescaline, peyote, mushrooms. These are things that can induce hallucinations, and the patients don't come in. They generally will not come in hemodynamically unstable. They may appear acutely psychotic when they're in the throes of visual auditory hallucinations, okay? But they are not going to come in generally with hemodynamic compromise or with any sort of respiratory depression. It's a different clinical presentation than the benzos, the narcotics, the phenobarb, or the cocaine, all right? The cocaine patient, although very agitated, will not be having delusions. They might be somewhat grandiose, but they're not delusional, right? And the heroin, the phenobarb, the benzos, the patient's going to have a lot of symptoms of CNS depression, but again, they are not delusional. They're not struck with visual auditory hallucinations. They might be the patient who are ingesting hallucinogens, and they can be obviously marijuana smoked, hashish can be baked into the foods, mescaline, peyote, LSD. These things can be ingested again orally. Generally, none of these are shot intravenously. Patients might be delirious and present with bizarre behavior. That's because they're having delusional fantasies and they're not interacting in a typically reality-based fashion. Pharmacologically, what these things can do, again, not to the point of generally being life-threatening, some of these drugs, some of these hallucinogenic agents can have anticholinergic properties. And think back about the anticholinergic side effects of, say, tricyclics. Tricyclics obviously very different in terms of the toxicities compared to the hallucinogenic drugs, but when they share anticholinergic properties, they can look similar in that regard. And that is that they can look flushed, the skin can be very warm but dry, the patient's mouth is very dry, and they have dilated pupils. So remember, looking at the pupils, if you're told on the question something about the pupils, pay attention. Because in the overdose patient, dilated pupils, think tricyclic overdose or anything that gives you anticholinergic effect. In constricted pupils that are still reactive to light, although it might be hard to determine that they're reactive to light because they're so small to start with, think about narcotic overdose. Constricted pupils, narcotics, dilated pupils, tricyclics, or anything with anticholinergic effects. The patient with intoxication from hallucinogens can be, again, because it's somewhat delusional and having trouble acting in a reality-based way, can be fairly well agitated. Not to the point, let's say, that they're hyperdynamic, hypertensive, tachycardic, and run the risk of seizures. Not at all. But they can be physically, behaviorally agitated, and that will generally treat with some mild benzodiazepines just to calm them down. Again, having patients come in with marijuana, quote, intoxication in the emergency room is quite rare because there is no significant hemodynamic compromise to any of these. If they are brought in, it's typically because in their delusional state, whether it's pot, marijuana, or something stronger in the hallucinogenic family, they're becoming agitated, acting in a bizarre fashion, and usually being brought in by friends, neighbors, or perhaps even the police. Contrast one particular hallucinogenic drug with the ones I've just mentioned, and that's phencyclidine, which is termed on the street as angel dust or dust. And usually it's mixed in with people who are smoking marijuana. It's mixed into the pot, into the cigarette, the marijuana cigarette. And besides the typical marijuana-type behavior, the patient will have a great deal of agitation, and even violent agitation. Violent agitation in someone who admits to smoking marijuana and nothing else, you can suspect that that patient has also ingested phencyclidine. And it might not be a knowledgeable ingestion of that phencyclidine. The marijuana might have been laced with phencyclidine or angel dust, and the patient can become quite agitated. And again, this kind of agitation will treat in the emergency room with short-acting intravenous benzodiazepines. Okay, I want to move on now from overdoses with ingested drugs to some other toxicology you may be presented with on the boards that is also from ingestion, but not obviously from a recreational drug point of view. And there are things in our environment, our daily environment, that we're exposed to that can present with intoxication. And you're going to need to know that if these patients present to the workplace clinic, to the university health clinic, to the emergency room, or even the doctor's office, the ambulatory care center, you need to know how to recognize these toxicities. The first one that I'll discuss is, in fact, much more common in children. If I say what environmental exposure puts kids at risk, particularly kids in old buildings, in poor neighborhoods, in urban areas, obviously you're going to think of lead intoxication, which is far less likely to present in the adults. It used to be that adults would become inadvertently lead poisoned by drinking homemade alcohol. And this was typically long ago, or even some parts of the country now where people find it cheaper to make their own alcohol than buying it in the store, and that they create what's called moonshine. And it used to be that moonshine was sometimes produced in big radiators, old radiators from cars or trucks that in those days contained a great deal of lead. And so the alcohol that they were distilling in these big lead-lined pipes were going to give them, with chronic use, lead intoxication. And that was a form of renal insufficiency seen in those periods. It's rare these days to find someone who's ingesting enough homemade alcohol in lead-contaminated pipes that they'll present with renal insufficiency. Lead intoxication in the adult is actually quite rare. It's much more common in the kids, and in fact the presentation will be fairly similar. And there are acute presentation in the kids as well as in the adults, and then the more chronic one. Where does lead end up in the body? 80 to 90% of lead, PB, or lead, ends up in the bones. About 10%, and about half of the 10% ends up in RBCs. So this will tell you the patient will have anemia as a presenting complaint. In children, in the acute ingestion, and where do kids get it? Because they are hungry, they're poor, they live in old, poor apartment buildings, the apartment hasn't been painted for generations, the paint on the walls is peeling, and it's lead-based paint. They ingest the paint, they absorb it therefore by GI route, although lead can also be absorbed by inhalation or through the skin. But again, we don't have that kind of environmental exposure these days to lead. But typically in children it will be eaten, and acutely the kids could come in with CNS toxicity, very lethargic, maybe not acutely lethargic, but over hours, days, even weeks. They might even progress to the point of coma. But again, you're not going to get that dramatic a presentation probably even in the kids. Chronically, the CNS after lead exposure can have irreversible neurologic damage, and it is something that is tested for in all children with learning disabilities, particularly in poor urban areas, is blood levels of lead. Because with chronic exposure, these children can have irreversible cognitive function impairment, end up with learning disabilities, and even to the point of appearing to be mentally retarded. Hopefully we discover these kids, and lead screening of children is very common, again, particularly in large urban centers, because we want to catch the kids before we have them with severe, irreversible lead toxicities. Another heavy metal that is in our environment, particularly in the environment that kids might be exposed to and inadvertently be exposed to, is mercury. How will you be told that the patient has mercury poisoning? You'll probably be told that the patient was exposed to a broken thermometer or a blood pressure, not the cuff, but the sphygmomanometer, which has a column of mercury, broke open, and these little fluid liquid beads of mercury were contacted either through the hand or the kids got on their hands, put it in the mouth, and they've been exposed to mercury poisoning. There's a little sort of micro industry, a cottage industry of doctors who are telling all kinds of patients, adults, with all kinds of diseases that what you have is mercury poisoning. And it's basically just a ruse, a little way to get the patient involved in all kinds of treatments that the doctors are selling. But real mercury poisoning that you'll see on the boards will be people who have had exposure to broken thermometer or where there's an obvious exposure inadvertently of mercury. It's usually gotten onto the hands, then ends up in the mouth. It's also in some paints with certain mercury-based paints. Again, this is not as common a source as the broken thermometer, which is quite easy to break around the house. It's absorbed through the skin, through the GI tract. We can inhale mercury as well. And the problem is mercury is very effective at getting across the CNS. And that's where you're going to see the toxicity. Patients get it's not like the lead toxicity, where patients become lethargic and to the point of coma even. Mercury, on the other hand, has you very excitable, even to the point that you start with tremors and get very more excitable, and even in the severe cases can progress to the point of seizures. All right? Again, I doubt you'll see more than one question on the boards, if that many, on mercury poisoning. Far more likely, you'll see kids who have been exposed to lead with the lead toxicity we talked about. Besides CNS involvement, where else can we run into problems with mercury poisoning? It can get through inhalation again. It can get into the lungs. You develop an interstitial fibrosis pattern, not a consolidated lobar type pneumonia, but an interstitial pneumonitis. There's also a great deal of GI toxicity that is, again, nonspecific, nausea, vomiting, nothing specific that tells you that's a mercury poisoning. You're going to have to get the history of the direct exposure to the mercury. Fortunately, there's a treatment that is somewhat successful for mercury poisoning. That's chelation therapy. And for these patients, we're going to use either dimercaprol or penicillamine. And these will hopefully sufficiently chelate the mercury. And this is, again, not going to be a long-term chronic problem for the patients who have been exposed to it inadvertently. Let's move on to our patient who is our unfortunate burn victim. 32-year-old fireman is caught in a fire and is briefly trapped under a burning staircase. Right away, what does that tell me? Suggests to me that the question is suggesting that the patient is in an enclosed environment. Again, smoke, enclosed environment, something should be coming to mind. He's quickly extracted and brought to the emergency department. He has a respiratory rate of 14, or maybe it's up to 24. He is, or maybe he's not, fully alert. We'll discuss the various approaches to these various clinical presentations. He weighs 220 pounds. He does or doesn't have soot in his mouth. The question is not going to say he does or doesn't. The question is going to give you one scenario or the other, and we're going to talk about the importance in distinguishing between these presentations. Soot in his mouth, his nose, and on his face, and his sputum may be, or maybe not, carbonaceous. In a word, that means he has black or gray tinged sputum. The nasal hairs are or are not singed, burnt. He has no stridor or hoarseness, or maybe he does. We'll talk about the different approaches to these different presentations. His lungs may be clear or they may not be clear to auscultation. And we'll talk about, again, the different approaches. He has first-degree burns, and we'll talk about what that means, of his right leg, and second- and third-degree burns on his right arm and chest. Now, burns are a major category of severe injury that will present in the emergency room and present on the boards. So it's important to understand burns and know the approach to the treatment of burns very adequately. Let's talk about where the damage from burns comes to. Why is this such a life-threatening illness? Well, first of all, we have smoke inhalation. Even people who have not been burned, who have been exposed to the fire, have the smoke exposure. We've already spoken about earlier on this tape about carbon monoxide poisoning. So again, you need to assess in any patient who's been burned, you have to wonder whether they also have the problem of carbon monoxide poisoning. So let's not forget than in our patient who's brought in by the fire department, severely burned, with severe burns, which we'll define in a moment, all of their body. Let's not just start rushing to deal with their hypotension and the treatment of their wounds, and perhaps the need for treating the evidence of the burnt respiratory tract. But let's always remember that right away we have to think about carbon monoxide poisoning. All right? And we measure the carbon monoxide saturation. Again, the PO2 on a blood gas is not at all reflective of carbon monoxide poisoning. We want to measure the carbon monoxide level right away. The other very serious, life-threatening mechanism of injury in the burn patient is, again, they could be burned anywhere, but respiratory burns. The question might tell us that they're in an enclosed environment with a lot of smoke exposure. The question might tell us for respiratory burns, these various clues that we just went over in this case scenario. For instance, for respiratory burns, I want to see if there's evidence of smoke inhalation injury where the nose hairs are singed. I see soot in the mouth, soot in the nose. All right? I hear evidence just by the patient talking that they have laryngeal burn and they're hoarse or they're stridorous. Hoarseness or stridorous. These are important signs and symptoms of laryngeal burn or burn exposure. And in the respiratory tract, the parts that are more proximal, the nose, the hypopharynx, the larynx, those are the areas in the respiratory tract that are most susceptible to severe burn. Because as the heat passes down through the respiratory tract, it's more effectively cooled. It's this initial hit we take in the nose, in the larynx, that will cause the biggest problems. And we're going to look for clues of severe respiratory burn on this simple physical examination. We're looking for singed nose hairs, soot, nose, mouth, carbonaceous or black or gray sputum. These are all clues that this patient has had a respiratory burn. And in that patient, besides worrying about a carbon monoxide poisoning, I'm going to worry about airway compromise. Because if it's been burned, it's going to get edematous. If it's getting edematous, it's going to obstruct. And I have to think very early on about intubating the patient with the respiratory burn. Now, we said in a patient with pure carbon monoxide poisoning, if I'm in a room and the fire's in that corner and there's a lot of smoke and I have no direct burn, but I have all this carbon monoxide inhalation, my PO2, as we said, even with severe carbon monoxide poisoning, my PO2 can be normal. However, the patient can have both carbon monoxide poisoning and be more closely exposed to the fire and have a respiratory burn where they are severely hypoxic. And you should have a low threshold in patient with a respiratory burn, with the signs and symptoms we just discussed, to intubate the patient early. Because what's going to happen is their larynx is going to become progressively more and more edematous. The patient will become hoarser and hoarser, more and more stridor, which is loud, large upper airway wheezing, as opposed to the wheezing that you hear in the lung fields with a stethoscope. That patient you must intubate. Now you have protected the airway. You have not assured perfect pulmonary health. The patient may have deeper, more extensive burns in the airways, and you'll know that from bronchospasm. And you'll know that by looking at a chest x-ray and seeing perhaps the development of non-cardiogenic pulmonary edema. Or you'll know that by doing a bronchoscopy and seeing damaged airways, distal to the larynx. But again, early on you want to intubate the patient with any suspicion of severe respiratory burn. All right? So carbon monoxide poisoning, specifically, we already talked about the treatment earlier, 100% O2, a very severe hyperbaric oxygen. But if it's a severe burn patient with severe respiratory burns, it's no simple matter to get the patient from the emergency room to a hyperbaric chamber. You're going to want them in a very intense monitored setting like the emergency room. The respiratory burn patient, early intubation. Early intubation. Before laryngeal edema has progressed to the point of laryngeal obstruction, now you're faced with a patient you need to do a pharyngotomy on. Okay? So again, these are the major issues to address acutely as the patient arrives in the emergency room. Blood gas, CO2 measurement, the physical exam to tell you whether the patient has significant respiratory burns. If they do, you're going to intubate them. Now, this is a good way for the patient to have a fatal outcome early. But again, this we could hopefully address rapidly, and then we need to think about the other pathways by which these patients, these burn patients, can be severely injured. Now remember, one of our best insulators against fluid loss is the skin. And when the skin is damaged, we're going to have a loss of this important barrier, and we can lose tremendous volumes of fluid, and the patient can become hypotensive to the point of shock and death. So we need to be aware of how to assess a patient in terms of how much burn they have. And there's what we call the rule of nines. Okay? Which you score various anatomic sections by 9. The face is 18. Face, 18%. Chest and the back are scored separately, 18%. Front is 18, back is 18. The arms, 9. 18 again, front and back. And the legs, they're bigger than your arms, more surface area, 18%. Okay? This is the rule of nines. And this is how you calculate what percentage of body surface area has been burned. And you'll hear on the radio, it had 30% burned. What do they mean? Well, they had some combination of body parts that were burned, adding up to 30%. Okay? We didn't take a ruler and measure the patient. We did this quick calculation. Now, obviously, there can be different sections of the body that are not completely burned, and you can get partial score. And one way is to measure the size of the hand on any particular body part counts for 1 point. So if they have 1, 2, 3, 4 hands worth of burn, you don't get, let's say, a full 18%, you get 4%. You'll get the idea. But on the boards, they're not going to give you a picture and ask you to map out how much burn there is. You're going to be told the patient is completely covered on their back and trunk, that's 36%. Or they covered both legs and an arm, that's 36 and 9, okay, 45%. All right? And those are big numbers. Now, not only do you want to know the body surface area involved, but you want to know, is this a first-degree burn, second-degree burn, or third-degree burn? And obviously, the higher the number, the more severe the burn, the more aggressive we'll be in terms of keeping the patient in the hospital, admitting them to the ICU, and monitoring them very closely. So besides the rule of nines, let's talk about how we define a burn in terms of severity. And we have first-degree burns. What's a first-degree burn? You go to the beach, you sit out too long, you didn't put on enough sunblock, besides putting yourself at risk for melanoma years later, you burn yourself. And you come back from the beach and you're awfully sore, and you're awfully red, and it's awfully painful. And that tells you that the nerve fibers in that skin is still intact. The skin is usually red, tender, doesn't usually blister. Once you blister, you're a more advanced burn. And the patient is not at risk of any significant long-term injury. So first-degree burn is erythematous, very painful, not usually blistering. These patients obviously don't get admitted to the hospital. Some of these patients are in so much pain from a bad first-degree burn that they're in the emergency room. And you'll give them cooling lotions. You'll make sure the patient isn't hyperthermic in addition. And these patients don't generally stay in the hospital. Second-degree burns, the skin could look worse than erythematous. It can actually look like the skin is becoming compromised, but it's not dead yet. It is not full thickness necrosis of skin. Second-degree burns can be either partial or full thickness of the dermis. And this is a more severe form of injury, obviously. This is usually still painful. The skin might be somewhat different than just red. It might be a little gray. And in this patient, the skin appendages are still intact, meaning the sweat glands are intact, the hair follicles are intact, and the pain fibers are intact. So these patients can be exquisitely painful, all right? Because, again, they have not burnt all the skin appendages. The hair, the sweat, and the nerve fibers are intact. Intact. And that is in distinction from a third-degree burn, which is deeper, does involve the skin appendages, and you have full thickness necrosis of skin, which therefore, if you have full thickness necrosis, you lose the hair follicles, you lose the ability to sweat from here, and you don't have pain. These patients are often anesthetic. With the worst burns, paradoxically, because you've burned through the nerve fibers, you might not have pain. And the skin might be very shiny, very waxy, white, gray, black, from, again, the skin full thickness necrosis. All right? These are the patients who are obviously going to need skin grafts, as well as some of the second-degree burns. And obviously, a patient who has been exposed to a fire does not come in necessarily well mapped out with exactly the limbs matched the way you would expect to give you an easy score. The question will tell you what areas are burned and what degree of burn it is. And this is important because that will determine, that will be your guideline on who you're going to admit to the hospital. First degrees, rarely. Second degrees, often, especially with respiratory compromise. Third degree burns, always. Okay? Now, the other important issue, besides giving the patient a label and determining whether the patient needs to be hospitalized based upon the degree of their burn and the percent of body surface area, is, and this is a very favorite step 2 question, is, because it's quantitative and it's easy to calculate, is how much fluid does this patient need? Remember, early on they could die of carbon monoxide poisoning and respiratory insufficiency from a respiratory burn. Early on, as well as time goes by, if they're not adequately repleted, they are profoundly hypovolemic. They will damage capillaries throughout the body, and there's capillary leak all over, particularly in the lungs, and they can third space tremendous amounts of volume as well as have insensible losses because they've lost the skin barrier. And these patients can die a hypovolemic death. So it's very important to understand how to aggressively replete this patient. And there's a straightforward formula. And that is, you multiply the body surface area times kilograms of body weight times 4 cc's. Let's say I have body surface area that is 25% burned. Let's make it our fireman, which is 220 pounds for a reason. Okay, it's 100 kilos. So we take out the percent sign. We multiply 2,500 times 4 equals 10,000 cc's, or 10 liters. So the question says, this fireman who has 20% burns burns over 25% of his body surface area. What kind of fluids will they need, and how much, and at what rate? You need to be able to answer all three of those questions. Number one, these patients, we will generally, the first choice would be, the choice of fluid be lactated Ringer's solution, an electrolyte solution. That would be my first choice. If they don't have that, I would go for normal saline. Normal saline being 0.9% saline. They might say 0.9% saline, they might say normal saline. If they give me these two choices, I'll go for Ringer's lactate. If they don't give me this choice, but they give me this and all kinds of D5, D50, albumin, etc., this is what I would start with. But my number one choice is lactated Ringer's electrolyte solution. That just tells me what kind of fluid. Now, how much fluid does this patient need? 10 liters. This formula tells you specifically how much fluid you need, what kind and how much you need, but we're talking about during the first 24 hours. Okay? This formula is fluid requirement in first 24 hours. And we just said 10 liters. Now, how do I give those 10 liters? Do I give 9.9 liters in the first hour and then drip in the other 100 cc's over the next 23? Obviously not. The proper distribution of this fluid in terms of liters per hour is you want to give half of this total in the first 8 hours. So I'll give 5 liters, 5,000 cc's in my first 8 hours. And then I'll give 25% in the next 8 hours, which would be 2,500 cc's, and 2,500 in the last 8 hours. So here I have my 10 liters, the first 50% in the first 8 hours, and the additional 50%, or in this case 5 liters, over the next 16 hours. That's the first 24 hours. What formula do I use thereafter? I want to assure adequate hydration to maintain adequate renal function. And for this calculation, I want to give enough fluids, and I'm gauging it by my urinary output, for which I've placed a Foley catheter. I want to maintain, after the first 24 hours, I want to hydrate the patient sufficiently to maintain 1 cc of urine output per kilogram per hour. So if I weigh 70 kilos, or in this patient, this fireman, 100 kilos, I want to see about 100 cc's of urine per hour, or 2,400 cc's that day. If I'm not, then I'm probably not giving the patient enough fluids, and they're hemoconcentrating, they're renally vasoconstricting. I'm going to end up with renal insufficiency on a pre-renal azotemia basis. So I want to give enough fluids. This will be a very good guide to how much fluids they should be getting. Okay? Let's just, for practice, go through one more case. Let's say I tell you a patient has burns over 30% of their body surface area, and they weigh, say, 60 kilos. How much fluid do I give them in their first 8 hours? All right? First 8 hours. That's specifically what we're trying to answer in the question we have now. 30 times 60 is 1,800. Don't forget to multiply by 4 equals 7,200 cc. In what duration of time should that be given? That's the 24 hours. The question I've just posed is, how much do you give in the first 8 hours? First 8 hours, we give 50% of that, so we're going to give 3,600 cc's in the first 8 hours. Simple. Simple formula to remember. Okay? Body surface area involved times kilograms of weight times 4 cc's. Okay. Again, choice, fluid of choice, lactated Ringer solution. Okay. So we've talked about our concerns about carbon monoxide poisoning, and as you recall, carbon monoxide poisoning can affect the CNS, affect the mental status, affect cardiac perfusion, give chest pain, signs of left ventricular dysfunction, hypotension. We talked about looking for, number one, carbon monoxide. Number two was looking for evidence of respiratory burn. Think about the laryngeal edema, and we're going to intubate early. We talked about the rule of nines, how to calculate body surface area, and how to replete the fluids. What else do we need to consider? Well, these patients are almost always in burn units. These patients are highly ill. They need to be cared for in highly specialized units. And in any given city, there's usually only 1 or 2 hospitals that have burn units. In New York City, for example, in a city of 9 million people, there are basically 2 major urban hospitals that have dedicated burn units. That doesn't mean the local emergency rooms don't stabilize the patient, but then those patients get transferred to the burn units. And the burn units is because that is where you have surgeons typically who are specialists and have done special training in management of burn victims. We're not talking about the early hydration. That any ER and any step 2 student should be able to answer. The more sophisticated management is the management of the skin injuries of the burns. And you're not asked to be burn specialist for step 2, but you do need to know the general approach to the management of the skin burns. And that is, first of all, we will sterilely dress, well, it doesn't remain sterile for very long, but we dress the wounds frequently after hydrating the wounds. Several times a day, we're going to come off, remove the bandages, rehydrate the skin, and rebandage it. Any areas that look necrotic or infected will get topical, not systemic antibiotics, but topical antibiotics. And the typical antibiotics we use is sulfadiazine is the common antibiotic. All right, so that's where you'll hear the word, let's give the patient some silver, topical silver, sulfa antibiotics. That's in the earlier second-degree burns. If there are necrotic areas, those areas will have to be debrided, and ultimately they'll have to be replaced with skin grafts. You're not going to be asked on step 2, where do you take the skin to? At what point do you do the skin graft? You need to know severely denuded skin, though, necrotic skin. Skin grafts will repair that area, and early skin grafting is important to prevent contractures. Skin burnt around joint spaces we are particularly aggressive with in terms of skin grafting to prevent the contractures of the joint that can ultimately lead to permanently contracted joints. So the burn specialists are early on going to very aggressively do skin grafting for areas near skin, areas of skin near joint spaces. And one last particular management issue in terms of the management of burns that, again, you're not going to be asked to perform at the level that you're taking step 2, but that you need to know to call the surgeon to do is patients who have circumferential burns. Patients with circumferential burns are a particular risk for vascular compression and further ischemia and damage, and even compartment syndrome, whether it's in the hand or down in the leg. These areas, if they have circumferential burns and there's poor ability for vascular flow, there can be edema in the area without any ability for expansion, and you end up with a compression compartment syndrome. A compartment syndrome is seen in other injuries, but especially in the patient with a circumferential burn, where things are tightly packed in a compartment. And by tightly compact, what are we worried about? We're worried about the vessels are compacted, and so you have localized ischemia, and the nerves can be compacted, and you'll have anesthesia in that area by the compression. And if you don't rapidly relieve this compaction, this compression, this compartment syndrome, you'll have permanent loss of function of those soft tissues. And these patients who are at greatest risk are the patients with circumferential burns, and they form an eschar around the entire skin that can cause compression, cause a compartment syndrome, whether it's the upper extremity or the lower extremity, and the surgeons there are asked to do an early escharotomy, meaning peeling away all the eschar that forms over the circumferential burn to prevent the compartment syndrome. Again, finally, let's review it again. Early carbon monoxide, suspicion of carbon monoxide poisoning. Assess carefully for evidence of a respiratory burn. Look in the nose, look in the mouth for soot, singed nose hairs. Look for evidence of stridor, large airway obstruction for laryngeal edema. Those patients will need early intubation. They will also die of hypovolemia and shock. We've talked about how you replete their fluids. Next, you need to be very attentive to their skin, local skin infections. They'll get frequent dressing changes, and the interns who work on the burn unit are constantly doing dressing changes all day long, moistening the area, doing the dry dressing around that moistened area, coming back several hours later, removing it. If the area has any evidence of superficial infection, topical antibiotic sulfadiazine. We do not use prophylactic antibiotics unless we have specific systemic infections. And again, for the patient with a circumferential injury, look early for an escharotomy. And that is a good general approach to the emergency room and then early management of the burn victim.